Hi, everyone. This is Emily Leffler speaking, and Isaiah Lewis and I were working on Domain 3, Topic E, Accreditation Agencies and Coding and Billing. So I'll be presenting this portion on accreditation agencies. And we'll start by looking at this concept map I've created to help you visualize how all of these different agencies are connected and needed for the healthcare system, especially government-run programs. So specifically, we'll begin with the Joint Commission. And the Joint Commission is a nonprofit organization that is an accrediting body for healthcare organizations and programs in the US. And CMS, which we will talk about in a minute, is the government entity that approves them to be that accrediting body. Okay, so here's CMS, the Center for Medicare and Medicaid Services. So this is a large government organization that runs the Medicare and Medicaid programs. CHIP also falls under CMS, and they have various roles that are more specific, but for our purposes today, they're Medicare and Medicaid. They are the organization that runs those. Okay, so let's get into Medicare and Medicaid more specifically. Medicare is a federal government sponsored health insurance program, and it's for Americans age 65 and older. Some with certain disabilities can also qualify for Medicare without that having reached that age. It includes parts A and B, and then there are other parts as well, which we're not going to talk about today, but part A is for hospital stays and hospital care, inpatient. And part B is for outpatient care, like a physician's visit in a clinic or in a hospital. But part A is kind of automatic once someone signs up for Medicare, and part B is optional for Medicare participants, and there may be extra costs associated with copays and things for part B. So Medicaid is another CMS program, but it is jointly run by the federal government and the states. And you'll see below a card from Texas Medicaid, but it's a health insurance program for low-income households. So this is another accrediting organization. This is DNVGL Healthcare, and they're a Norwegian company that's also approved by CMS to perform the certification and accreditation of hospitals and other healthcare facilities in the US. Okay, and next is CHIP. So similar to Medicaid, it's a program for health insurance for children, though, that's run by the states and the federal government together. And pregnant women may also qualify for CHIP. And like Medicaid, it's health insurance, and it provides inpatient and outpatient coverage.
All right, this is Isaiah Lewis, and we're going to be talking about coding and billing a little bit. So first off, I want to start by going through the initial steps for the process of coding and billing. First, you need to obtain a National Provider Identifier, or an NPI. This is a unique 10-digit identifier that, similar to a social security number, is kind of going to follow you as long as you're a healthcare provider, no matter what job you are actually at. And there is an entity type 1 and an entity type 2. Entity type 1 is something that all healthcare providers need to have. It is an individual provider number specifically associated with you. And then entity type 2 has to deal with corporations primarily. So if you are working in an organization that is incorporated, they have an entity type 2 NPI. And then credentialing with insurance companies is important as well. This is kind of what we think of as non-network versus network providers. Some will require you to have this in order to work with their insurance, and it's going to be dependent on the insurance company whether or not it's important, and also will factor into your coding and billing whether or not you're in network or not. Basically, it assesses and verifies your qualifications as a provider and kind of just verify and lets the insurance company as well as the patient know that you are going to be able to do what you say you are going to do. And then that logo at the bottom is the National Plan and Provider Enumeration System. That's where you're actually going to obtain your NPI from. And then the next step is going to be insurance verification. So from your patient, you're going to need their name, their date of birth, and their insurance information. A lot of times that comes in the form of an insurance card. Oftentimes the insurance card itself is necessary to have on file. That's going to have their whatever their member ID number, whatever it really is for their insurance company, oftentimes like a subscriber ID number or a benefits number. And from here, you're going to need to actually get in contact with their insurance company. So you need to make sure you know what their insurance company is from the patient themselves. There you can verify their network status, their policy number, and then any M&T benefits slash the units that they are actually approved for, and then how much time you have to complete those units. For example, a 3-month period to complete 8 units, right? And also any exclusions to M&T, so you know what you will and won't get paid for. And then payment-wise, you want to know about any copay, any deductible or co-insurance if they're using multiple insurance plans to pay for the coverage, pay for the services, I mean. And then you also want to check and see if they have if they need prior authorization, as well as if they have that authorization and then the number associated with that. You can also get that from the patient themselves. And you want to write down the details of the call. So the representative name, the date, what you discussed for your own records in case any issues come up in the future. And so here's a CMS 1500 form. We're going to run through it just to kind of check everything off. It's a common issue with denied cases and delayed cases that you really want to get paid for. So we're going to talk about it. Some of these are unnecessary for an RD, or they just don't really need to be filled in. So we're going to skip over some of those. Starting at this first half, we have number 1. You're going to choose their medical insurance, and it even tells you what their number is going to be for 1A. You're going to put their insurance ID, and then 2, patient's name. And we're going to look at 2, 3, and 5 here. You want to put the patient's name, their birth date, their sex at birth, and then their address, as well as in 6, you want to put their relationship to the insured. So this is the person you were treating, not necessarily the person who is insured. 4 and 7 is the insured's name as well as the insured's address. For example, if you're treating a child, they are most likely on their parents' insurance plan. This is going to be the parents' information, right? Then we're going to jump to number 10 over here. Is the patient's condition related to an accident or employment? Not always filled out, but if it is related to that, you're going to want to put that in there. And then next we go to 12, which is going to be the patient or the authorized person's signature. Oftentimes, if the patient is not over 18, someone else will need to sign for them. And then the date, as well as 13 is going to be the insured or authorized person's signature. Situation where it's the parent and the adult, that's the adult signature, whoever holds the insurance. It is also possible that they have their signature on file, so that can be written in there as well. And then now moving to number 17 is the first that relates here, is the name of the referring provider. This one does not always need to be filled in. Depends if their insurance company requires a referral. 17A is going to be blank, and then 17B is going to be the referring provider's MPI. This is oftentimes a physician or something of the sort. So you put their name and their MPI. And then moving on to 21, this is going to be the diagnosis code. So it's an ICD-10 diagnosis code. You want to start with you want to use the highest specificity with your diagnoses, as well as the highest priority. So you're going to start with what is being treated. Keep in mind, this is the diagnosis code given by what is likely a physician. You don't actually do the diagnosing yourself. And then 23, if prior authorization is necessary, you're going to put that in there. And then 24 is this big box where we're actually going to talk about the services provided. So you're going to put the day, and if it's one day, you're putting from that date to the same date. Place of service, there's codes for where the service is rendered. For example, 49 is going to be a private clinic. And then moving on to D, it is the CPT or HCPS code, kind of just saying what services were rendered. And then if there's a modifier, that's also there. And then moving into E is the diagnosis code. So you're probably going to be putting A because that is the primary diagnosis relating to box 21 up there. F is the charge. G is the amount of units. And then J is the rendering provider. So that's going to be your own MPI. And then something to keep in mind that we'll talk about later is an incident to a physician specifically, is if you are providing this service in a multidisciplinary organization where the physician is the person who is actually billing it, because you cannot bill directly as a RD in many situations. And then moving on to 25, it's going to be your federal tax ID number, and then that's usually going to be checking the box EIN. And then 27 is whether or not you accept the assignment. This is going to be, sorry about that. 27 is whether or not you accept the assignment, and if you are credentialed with an insurance company, you have already agreed to a specific payment and you would be checking yes. 28 is going to be the total charge for the services, and then 29 is going to be the amount paid from the patient or the primary insurance. 31 is provider signature, so your own signature and date. 32 is where you actually rendered your services, the date of that, the address of that location. And then 33 is your billing address as well as your phone number. And to describe the requirements for insurance services, we're just going to run through some general things that pop up. So physician referral, whether or not a physician needs to refer this patient for your services. Something that impacts this is type of plan. HMO, for example, requires referrals. PPOs do not require referrals. And then there's this other thing called a request for medical necessity. If you know the patient has M&T coverage, but they don't have a diagnosis, then you can make a request for medical necessity based on need to prevent diagnosis, treat an illness, injury, condition, or any symptoms that are accepted by the standards of medicine. This can be denied, but it is one way that we can kind of try and get help for someone even without a diagnosis. And then it's important to consider the conditions that are covered. Currently, RDNs are only included as providers for diabetes and end-stage renal disease outside of a primary care setting. Things like cardiovascular disease and IBT for intensive behavioral therapy for obesity require a primary care setting and must be billed incident to a physician. So hitting on intensive behavioral therapy a little bit more, this is under Medicare Part B specifically. Eligibility is going to be Medicare Part B beneficiary with a BMI greater than 30, and counseling must be completed in a primary care setting, which has to do with the scope of practice. You can provide the care as an auxiliary personnel under the supervision of a physician. And then when it comes to coding and billing, we've mentioned this a couple of times now, you need to bill this as incident to a physician. And it's going to be very similar here with the annual wellness visit. Eligibility is Medicare Part B for over 12 months, and you haven't received an AWV within 12 months. And it's covered by traditional Medicare as well as Medicare Advantage plans with 100% coverage, no copay, no deductible, nothing along those lines. Then scope of practice, once again, this must be billed in incident to a physician, so it has to be done within a primary care setting under the direct supervision of a physician, and that kind of covers the coding and billing as well as incident to, once again. And so just a quick definition for diagnosis-related groups. A DRG, or diagnosis-related group, is a patient classification scheme providing a means of relating the type of patients a hospital treats to the cost the hospital incurs. So just what patients are leading to what costs. And the 6 variables that will influence the diagnosis-related group assigned is going to be principal of diagnosis, the most important diagnosis, the one that is the priority at that time, secondary diagnosis, anything that goes along with that but is not the primary issue, and then surgical procedures performed, obviously that incurs a fair cost, and then comorbidities and complications, for example, obesity with the comorbidity of type 2 diabetes, and then the patient's sex and age, and then their discharge status, whether or not they're sent home to a different facility, so on and so forth. These all impact the cost incurred by the hospital. But that is about all that we have to talk about today. We have references and links for different sites if you want to read more into it. We've labeled them, so this one is for accreditation agencies, and then this one is for coding and billing. But that is the end of our presentation.